So we have these monthly community calls just to be able to have these awesome individuals such as Dr. Scott, who's on our medical board, to just share with our community all this important information to know when we navigate in plant sacraments and just many, many things. This month, we're going to be going over the Walsh method and how to safely taper off of medication. So I'll just create the framework and explain some things on the back end and then hand it over to Dr. Scott. So we'll go over the difference between Iboga and Ibogaine, a couple of safety risks and safety concerns when working with Iboga, the pharmaceuticals, the types, and the concerns, how they are contraindicated with Iboga, and then we'll go over to tapering and the Walsh approach. So what is the difference between Iboga and Ibogaine? Ibogaine is an alkaloid in Iboga. Both of them come from the plant tree bark of Tabernanthe iboga. However, you're able to extract Ibogaine from Bocanga africana. These are both sourced in Africa. However, they can also grow in other regions. The difference here too with Ibogaine is used more so in medical treatments, specifically for addiction, where Iboga is more for spiritual, psychosomatic, as well as addiction and many other things, but it is more in a ceremonial setting. As we are discussing different pharmaceuticals, it's important to just learn a little bit more on the safety side, both with the liver and the heart and Iboga. So Iboga, more specifically Ibogaine, is metabolized in the liver by the CYP2D6 enzyme. And Ibogaine has a bit of a short half-life of 4 to 8 hours when compared to its secondary metabolite, neuroibogaine. When it is converted, that's what it's converted into this neuroibogaine, which can range from about 28 to 49 hours. And it's lipophilic, meaning that it's fat soluble. It lives in the fat. So the lingering central nervous system and cardiac effects can last from days to weeks after the dose. And this is just what it looks like. This is its conversion here, moving from Ibogaine, converted by the CYP2D6 enzyme into neuroibogaine. This is why it's important for us to, if someone has a history of alcoholism, to do a liver panel test. So what we're doing is that we're testing for liver enzymes, for proteins, for bilirubin, for blood clotting. However, it does not test for the CYP2D6 specifically. You can do this through pharmacogenetic testing. And if you are able to have this done in advance, then we're able to see if you are a poor metabolizer, a normal metabolizer, or a ultra rapid metabolizer. So if you are a poor metabolizer, what that means is that Ibogaine stays in the system longer. There's less neuroibogaine, and you feel more of these acute effects in your system. There's a longer time in the medicine or in the experience. So typically what we do with these individuals is that we dose lower, and there's a slower dosing that happens. If you're a normal metabolizer, then you fall within that typical range, that standard timeline for onset. And then if you're an ultra rapid metabolizer, there's a fast conversion to neuroibogaine, meaning that there's a shorter visionary experience. You return to normalcy quicker and you feel clearer earlier. With these individuals, we tend to hear this feeling of not going deep. So instead of giving more and more Iboga, what we do is that we're just able to recognize this awareness that that person just may be an ultra rapid metabolizer. So it's important to note also the safety concerns with the heart. So Ibogaine binds to the HERG potassium channel. And the way that the heart works is that we have these potassium ions that are on the inside, and they go through this conduction process where they shot out to the outside. And what this is creating is a repolarization. So through that process, that's what's making the heart beat and creating what we call the Q to T interval. And it's what we're looking at when we are, or our EKG specialists are looking at when they are reading the EKG. So because Ibogaine is binding to these potassium channels, what's happening is that this conduction rate is happening slower, and there is an elongation of the QT interval. When this is a bit too long, or what happens with the elongation of the QT interval, is that someone can go into cardiac arrest. And just to note, Iboga is only 5% Ibogaine. So this is we still approach it just the same, and we require EKG testing so that we're able to see if there are any abnormalities within your heart rate or within the QT interval. In Ibogaine clinics, the way that they're able to mitigate this is by giving magnesium, either through IV or magnesium sulfate. It's able to compete with the HERG block effects, and it's blocking the L-type calcium channels indirectly and suppressing this delayed repolarization process. What we do as well to be able to mitigate is that we require an EKG. This is mandatory before arriving to our retreat. And we are also giving magnesium through glycinate or citrate, and as well as CMOS, which is rich in magnesium, potassium, iodine, trace minerals, and it has 92 of the 102 minerals that our body needs to operate. And just to take a bit of a closer look here, so each of these boxes is what's being counted, these tiny white boxes. In adult males, this is less than 450 milliseconds. For adult females, it's less than 470. And anything above 490 milliseconds is seen as a prolongation. So this would create a contraindication, and we would ensure that we're able to see this beforehand. And then because we're going to be talking about SSRIs and many things, it's just important to be able to take a look at how our neurons work. So what happens here is that we get an electrical signal that is absorbed into the dendrites, and that creates the signaling into the nucleus for the neurotransmitters to move down the axons into the synaptic cleft. As it moves through, the neurotransmitters, they bind to the receptors and either excite the next neuron fire or inhibit it and slow. This is why there's that famous line from Joe Dispenza, neurons that fire together, wire together, and basically just speaking to the creation of and the formation of habits. And then taking a deeper look, what happens when these neurotransmitters move, you are either creating, they are either moving into those receptors, they're binding to the next neuron, or what happens is that it goes into this reuptake where it's being reabsorbed. I'll move back a bit. It's just being reabsorbed into the original neuron. So when we talk about SSRIs, serotonin reuptake inhibitors, we see exactly what is happening. We'll take a closer look in a bit. So there's these three processes. It's either they're being reuptake, or they are going through diffusion where they're just being absorbed back into the body, or there is degradation where the enzymes are breaking these neurotransmitters down. So then we'll go into the types of pharmaceuticals here. And before we do that, we'll just, because we do talk about this term of washout. A washout period means giving the body enough time to fully clear a medication and its active metabolites before introducing Iboga or Ibogaine. So the half-life is the time that it takes for half of the drug to leave the body. The active metabolites are some drugs sometimes break down into other active forms. So for example, with Prozac, you have fluoxetine that is broken down into norfluoxetine. So we have the parent drug that can have a half-life of 2 to 4 days, and then its active metabolite could have a half-life of 7 to 15 days. So the total washout needed would be 5 to 6 weeks. This is just to take a look at what we're talking about when we're referring to washout. And then you have stimulants. The purpose of stimulants is to be able to increase alertness, focus, and energy. And most stimulants are increasing dopamine and norepinephrine in the brain by blocking reuptake. So that process of it going back into the original neuron, or increasing this release. And this raises the heart rate, blood pressure, and brain activity. So some of the common ones are Adderall, Ritalin, cocaine, modafinil. And why are these contraindicated with Iboga? There could be a cardiac overload. Both stimulants and Iboga increase sympathetic tone. So this could be dangerous as it elevates the heart rate and blood pressure. There could be acute T prolongation synergy, a heightened risk of arrhythmia or sudden cardiac arrest. or there is a neurotoxicity risk where the combined overstimulation of dopamine and norepinephrine pathways can cause seizures and agitation. So the recommended washout for stimulants would be, let's say for Adderall or Ritalin, 10 days minimum, for cocaine or other stimulants, 14 days, for modafinil, 10 days. We have depressants. These slow down the central nervous system, producing relaxation. And what it's doing, basically, it's GABA agonism. They're enhancing inhibitory GABAergic signaling. So it's creating calming, anti-anxiety, and sedative effects. So these are alcohol, your benzo, Xanax, Klonopin, barbiturates, C drugs, Ambien, Lunesta. These are contraindicated because they create a respiratory depression. And this can suppress breathing, rebound seizures. Stopping too fast can cause GABA withdrawal or hyperexcitability. And that's why it's important to be able to taper off safely. And they can mask danger, so it numbs your awareness if you are in distress. The recommended washout for these, for benzos, are 14 days, for alcohol, 7 days, for Z drugs, 10 days minimum. For antidepressants, what it's doing, they're normalizing mood and relieving anxiety, depression. So these are your SSRIs or SNRIs. They're blocking the reuptake of serotonin and norepinephrine. TCAs inhibit reuptake of serotonin and norepinephrine plus anticholinergic actions. And then we have the MAOIs, which are inhibiting the breakdown of monoamine oxidizers such as serotonin, dopamine, and norepinephrine. So your common examples of these are Prozac, Zoloft, Celexa for SNRIs, or Effexor, Cymbalta, TCAs. You have MAOIs as well, Nardil, Parnate. And why are these contraindicated? The serotonin syndrome, serotonergic stacking can cause hypothermia, rigidity, and seizures. They can cause QT prolongation, especially in citalopram and TCAs. And then there is also a CYP2D6 enzyme inhibition, which is reducing the ability for Ibogaine to be able to be metabolized, which can create accumulation and toxicity. So the washout period for SSRIs, 4 to 6 weeks, SNRIs are 2 to 3 weeks, TCAs are 3 to 4 weeks, and MAOIs are about 6 weeks. And this is just to take a look at what is happening. So the general difference between selective serotonin reuptake inhibitors and serotonin epinephrine reuptake inhibitors, SNRIs, are the types of neurotransmitters that are blocked from being reabsorbed by nerve cells. So then we can take a look over here at what's happening in the presynaptic neuron. So you have the serotonin blocks here that are blocking for the reuptake of serotonin and norepinephrine. And this is just what it looks like. And then we have MAOIs, so monoamine oxidase inhibitors, that work by blocking the monoamine oxidizers, the enzymes that are breaking down these neurotransmitters such as serotonin and dopamine in the brain. So by being able to block the enzyme, MAOIs allow higher levels of these key chemicals to remain available in the brain, which help to improve your mood and alleviate symptoms of depression. That's why working with cacao can be really beneficial. And in many indigenous cultures, they combine cacao with psilocybin. The reason is because the psilocybin is being broken down into psilocin, which is binding into the 5-HT receptors. And in cacao, you have MAOIs. So what is occurring is that these MAOs are breaking down the psilocin. So with the cacao, that's stopping the breakdown of psilocin so that you're able to have more psilocin available, and it's more effective in that way. That's when Troy and I do ceremonies, we work with both cacao and psilocybin together. So we just take a look at what it looks like here. The MAOs look like little Pac-Man that are eating the serotonin and these chemicals. So what's happening with MAOIs, they're just inhibiting that breakdown of the serotonin and allowing for increased serotonin concentrations. Antipsychotics, these are meant to treat psychosis, mania, bipolar, schizophrenia symptoms. The way that this is happening is through blocking dopamine, serotonin, 5-HT 5-HT2A receptors to be able to stabilize mood, reduce hallucinations. Why are they contraindicated with Iboga? The QT prolongation is a risk here. And then you have the opposite pharmacology. What's happening is that it's blocking dopamine while Iboga is activating it, which is creating conflicting effects. And then you have central nervous system instability, which is additive sedation. And this can be really just not good during ceremony. So it's important if we are tapering or if we are doing a washout, the atypical antipsychotics for 4 weeks minimum, typical antipsychotics 4 to 6 weeks minimum. So what's happening with antipsychotic medications, we see that the dopamine hypothesis of schizophrenia proposes that psychotic symptoms are caused by an overactivity of dopamine, specifically in the mesolimbic pathway of the brain, while negative and cognitive symptoms may be linked to low dopamine activity in the prefrontal cortex. So when we hear positive symptoms, this means that there is that overactivity of dopamine or the overstimulation of dopamine receptors in the synapse. And then what's happening with antipsychotic medications is that they're blocking the dopamine receptors so that it's able to have a decrease in positive symptoms. And then with hallucinogens, they alter perception, consciousness, and sensory integration, how they're working primarily through the 5-HT2A receptor agonism, increasing glutamate in the cortex and disrupting the default mode network. The common hallucinogens are psilocybin, LSD, DMT, mescaline, ayahuasca, ketamine, and MDMA. Why are they contraindicated with Iboga? They're overlapping pathways. So Iboga also modulates the 5-HT2A and MDA. So there could be an overstimulation and confusion. There could be prolonged dissociation or cardiovascular strain. So MDMA and ketamine increase HRBP, which can be fatal with Ibogaine's QT effects. So the recommended washout for these for classic psychedelics or plant sacraments like LSD, psilocybin, and DMT is 2 weeks. And for MDMA and ketamine is 4 weeks, especially because of the cardiac and serotonergic overlap. And then you have your anxiolytics. These reduce anxiety and promote calmness. What they're doing, benzos are potentiating GABA A receptors, sedation, and muscle relaxation. Buspirone, a partial 5-HT1A agonist, which is creating a mild serotonergic anxiolytic. The common examples are Xanax, Valium, Klonopin, Buspirone. Why are they contraindicated? There could be respiratory suppression. These are dangerous if you're vomiting or under Iboga-induced bradycardia. Withdrawal seizures if stopped abruptly before the ceremony, or serotonin risk, which is adding to the Iboga 5-HT load. The recommended washout for benzos are about 14 days. And for Buspirone is 2 to 3 weeks minimum. So I'll go ahead and hand it over to Dr. Scott.
So first a little bit about myself. So I was trained in traditional psychiatry. I'm actually originally from Germany, so a little more open-minded to natural methods always. And after a few years of doing traditional psychiatry, I just got a little dissatisfied and wanted to work towards a more root cause approach. So I decided to do a fellowship in Integrative Psychiatry at IPI in Colorado for a year. And then heard about Dr. William Walsh and his nutrient therapy. And so I did 2 trainings with him, a basic one in 2019 and an advanced one in 2023. And it was amazing. There were people from all over the world at that seminar. So since then, I've implemented more and more of the Walsh protocols. And we will go in detail over each one. But what I've seen is that it's a root cause approach, and that if there's enough time, so it requires time, we can do lab tests, bring this on board, and then slowly wean people off medications, or at least reduce them significantly. And so this is really good for people, who want to minimize medications. I like to use it in my younger patients too, because less is more when it comes to medications. So, and also, if you look at the mental health statistics in the US, and this is older data because it's probably increased significantly. In 2023, over 10% of US adults were prescribed antidepressants, and 8% of children aged 5 to 17 had taken prescription medications in the preceding 12 months. Now, this, I think, has increased drastically. COVID contributed to that. And so, from August 2021 to August 2023, the prevalence of depression increased by 60% among US adolescents and adults. And so this shows that whatever we're doing, it's not working very well. Of course, root cause is probably multifactorial, but definitely promotes, I think, looking into root causes and what's going on. And part of why nutrient therapy works is partly too that our food has gotten very depleted of essential minerals and vitamins, and that people eat because of time pressure and money too much processed food. So they are not only genetically predisposed to certain deficiencies, but then they just get them by not getting the nutrients that they need. So this is this is Dr. William Walsh, and he has studied nutrient therapy for 30 to 40 years, and has basically identified several abnormalities that we can pick up on a lab test. So it's a blood test and a urine test that we do. And then there is specific nutrient protocols that can be implemented. So basically, it's kind of like your custom multivitamin based on your biology. Once we have the initial evaluation and we started them, we still need to check a few things every here and there. But other than that, we just hold course. And for most people, slowly they feel better. It's subtle. And all of a sudden, they realize, oh, well, I'm not so depressed or so anxious. And then what we also see is that the medications start to produce side effects because they're basically getting too strong. So, yeah, so basically, nutrient protocols are designed to normalize the chemical balance in blood and brain, and they're essential for neurotransmitter synthesis. And so, for example, serotonin requires the amino acid tryptophan and B6. So B6 is one of the vitamins that's very important for neurotransmitter production. Zinc is. And so nutrient therapy is an effective approach that addresses the underlying causes of mental health issues. And again, it's based on laboratory results, so there's no guessing game. And so, yeah, so helps to minimize medications. So I use a specific lab that is what Dr. Walsh recommends. It's called DHA Laboratory. And so practitioners can sign up with that lab. And then the draw station is LabCorp. And LabCorps are all over the place, so it's pretty simple to find one. And yeah, and there is certain things you have to keep in mind to get accurate levels. The most tricky one here in San Antonio is histamine. And so we have to get one accurate histamine level in the beginning, but San Antonio people have a lot of allergies. So most people are on allergy medication. And so that can sometimes be tricky because it has to be stopped for 3 weeks before. And so otherwise, the other ones, you just stop all vitamins and supplements for 24 to 48 hours. So Dr. Walsh came up with these several different scenarios. So the first one is undermethylation, which is actually something that's been increasing a lot. And we have a big shift towards that, kind of a little bit faster than what would be expected on an epigenetic level. And Dr. Walsh thinks it may have to do with us consuming too much folate. Folate is in so many things, cereals, energy drinks, and then people take a multivitamin, all these things. So that's diagnosed by looking at the total blood histamine level. And so Dr. Walsh has his ranges, and then there will be the lab range, and they're different. Oh, Joe, could we go back one more? Yes, so thank you. And so basically, if the histamine level is above 70 nanograms per milliliter, that determines that we have undermethylation. And so that leads to diminished activity at serotonin and dopamine receptors, while it also simultaneously increases glutamate activity at the NMDA receptor. So this results in certain traits. So those are people who usually have a calm exterior, but on the inside, they're really tense. They're usually very high achievers, can have obsessive tendencies with OCD-like symptoms, intense routines. They're competitive, perfectionistics, can tend to have addictions, and can have chronic persistent depression, introversion, and rigid dietary habits. Overall, pretty successful people. And for about 20 to 30% of people, that never causes a problem. But if you put stressors and other things, on top of that scenario, then it can create a problem. So in this scenario, there is an adverse reaction to folate, and folate can actually make depression worse. And a lot of times patients tell me that there's certain folates that psychiatrists prescribe, like Deplin. It's a type of methylfolate. It's pretty high dose, and these people will feel that, oh, I feel worse on that. So the treatment protocol for this scenario, it includes certain supplements, SAMe, a calcium magnesium supplement, vitamins B6, B12, zinc, and vitamins A, C, D, and E. And so normally we continue antidepressants for a while until this kicks in, but if somebody is not on an antidepressant, then we can use 5-HTP or tryptophan as serotonin precursors. And so this scenario takes a while. Improvement typically begins after 4 to 6 weeks. And then recovery can take 9 to 12 months. But so it's a slow and steady progression usually. And again, this scenario I see more and more. Then the opposite of that is overmethylation, which per Dr. Walsh is folate deficiency. And so this also relates to the histamine level. And that's when the histamine level is low, less than 40 nanograms per milliliter. This is more rare. I don't see those people that often nowadays. And again, folate is in a lot of things nowadays. So the scenario there is increased activity at serotonin and dopamine receptors, while the glutamate activity at NMDA is decreased. So traits associated with this include anxiety, panic attacks. Those are usually empathic, caring people. They're not very competitive. They're very social. They like to socialize and talk a lot. And they tend to experience adverse reactions to SSRIs and SNRIs. And those may also be the people that when they get put on an antidepressant actually have a really bad reaction, like become one of those people that kill others or do something very irrational and violent. So Dr. Walsh has found that that was sometimes the scenario. So in an ideal world, it would be nice to be able to test that. And then you have a warning about being more careful putting these people on antidepressants. And so treatment for this involves folic acid in a specific dosing. So if you don't do enough or too much, it doesn't work all right. Vitamin B3, vitamin C, vitamin B12 in these two specific forms is cyano or hydroxycobalamin. And with this, I want to make patients aware that initially they could be a little more anxious for about the first 2 weeks. But then it's a gradual improvement. And so in about 8 weeks, they usually feel better. So that's that. Then we have pyrrole disorder. So that's a urine test we do. And so pyroluria, often I get a lot of people who are diagnosed with bipolar disorder, and actually they have pyrrole disorder. And that's actually the disorder that responds the quickest to nutrient therapy. So we do a urine test, and patients can do that at home, and they just mail it. So it's very convenient, and practitioners can get the test kit mailed to them, so they can do that at home, freeze it, and then the next day mail it. And so the urine test will show high pyrrole levels, and so this basically indicates a zinc and vitamin B6 deficiency. And so scenario, what's going on neurotransmitter-wise is decreased activity of serotonin, dopamine, GABA, and NMDA. So it's a hit on all sides, so to speak. So people with this condition, they can have severe mood swings, and they really struggle with stress. So poor stress management. They usually are not breakfast eaters. They have reduced appetite in the morning. They tend to be fearful, susceptible to fright, irritability, anger, histrionic and dramatic behavior. They tend to be more night people. And then their urine will have like a dark or mauve colored look from the pyrroles. And so treatment for this involves B6, zinc, evening primrose oil, biotin, selenium, glutathione, and antioxidants. And so of note is that stress makes pyrrole disorder worse, and pyrrole disorder makes your handling of stress worse. So it can be a really nasty loop. And when people have a period of stress, they are advised to increase their supplements for that time frame. And what's wonderful is that Dr. Walsh came out with a line of supplements because it gets pricey to compound these. So usually we compound these, but he has a Pyrrole AM supplement, which puts all the important vitamins in one capsule that people can take. And it's very reasonably priced. He wanted to make it affordable. So then I can refer, patients to the website and tell them what to buy. So this improves quickly. Yeah, it's usually, people feel better within a week, and within 4 to 12 weeks, it's better. All these protocols are kind of a lifelong thing. So it's just these people have a predisposition to these deficiencies. So should probably stay on that on some form and just consider that their personalized multivitamin regimen. But again, yeah, it's really helpful, and people realize that I can handle stress better. I feel calmer. So that one's pretty quick to treat. Then we have copper zinc abnormalities. And so that is so excess copper is pretty common in women. And so that's inherited on the X chromosome. And we women have this scenario where our copper levels almost double when we are pregnant. So if we cannot clear the copper properly, then the copper accumulates. And that has a lot to do with postpartum depression or postpartum psychosis. So the lab test will show increased copper levels above 110 and then low zinc levels below 90 and a high copper to zinc ratio. So this causes elevated norepinephrine and reduced dopamine activity, which is linked to the high copper levels. And so 95% of this high copper depression is in females because of the hereditary through the X-linked chromosome. And so that's also why often the traits show up during puberty, or they get worse during pregnancy or menopause. Or when people go on birth control. So those are people of a lot of anxiety, nervousness, postpartum depression, postpartum psychosis, hormonal fluctuations, sleep issues, can have irregular periods and tinnitus. And this can also, the high copper can present similar to ADHD, so difficulty focusing. Treatment, again, a lot of times zinc and B6 are major players, selenium, antioxidants like vitamin C and E, glutathione. And again, those people often those women don't respond well to hormones or birth control. And so there can also be an initial worsening, but from my experience, often when that happens, it shows that the nutrient therapy is really working, and you can work with people to talk them through, say, just stick with it, it will get better. It's usually only for the first 2-3 weeks. And then around week 3 to 4, it starts to improve. And then yeah, it takes 3 to 4. I've seen it take a little longer too sometimes, but just slow and steady progress. Now we do check, that's one thing we monitor the copper zinc balance, and then we also check the ceruloplasmin, which is the copper binding hormone, to see how much free copper is in the blood. And that's something we monitor every so often, because you also don't want to overshoot with too much zinc, and people respond quite differently. So it's, again, a very individualized protocol. Okay, and then we have toxic metal overload. And so these are usually people that have complex symptoms. They don't respond well to anything. And so, yeah, psychiatric medicine counseling don't really help. And so often they have personality changes, metallic taste, irritability, can have headaches, muscle weakness, abdominal pain and cramping, low energy. And that's usually then a warning sign to test for heavy metals and low zinc. And so, of course, lead is very dangerous, especially for children and their cognitive development. And then you treat, the metal toxicity with chelation therapy, calcium, zinc, glutathione, and antioxidants. And that's more rare. I don't see that very often. So, yeah, so this is the Walsh Research Institute. It's outside of Chicago. And here are some steps, if somebody wanted to do a Walsh protocol type taper, I would recommend going, and here's the website, to the Walsh Institute website. And there you can find, they have a list of Walsh trained providers. So you can look for a provider in your area. And then this provider will do an initial evaluation. And then Dr. Walsh has his basic first line, very comprehensive panel. And again, it will be run ideally through DHA lab, because they really specialize in this. But the draw station is LabCorp, so pretty easy to do. And again, the pyrrole test is a urine test you can just do in the comfort of your home and mail it off. So that's how that actually works. So a few, practical important things, again, like we said before, to get an accurate histamine level, you have to discontinue antihistamines for 3 weeks before. And often people don't realize, well, I take a Tylenol PM. Ooh, that has Benadryl in it. So usually kind of good to explain, all the possible options where one could take one by mistake. And then psychiatric medications can affect the histamine level. So whenever I read through the test, I have to keep that in mind that that will be affected. So, and it takes about 7 to 10 days, depending on how busy they are, to get this back. And then, yeah, there's periodic lab draws. Histamine, we don't necessarily even have to recheck. We just stay on that protocol, copper, zinc, and ceruloplasmin, and we recheck. And then very, very important, don't stop your psychiatric medications. That's always the danger. People get very motivated and think, okay, I'm going to do this. And these vitamins, they don't work immediately. So we continue those, and then we taper very gradually. And again, sometimes they just start to cause side effects because they're starting to be too strong because they're not needed as much anymore. And so you want to always do that under physician's guidance and really stay on there. Although eventually I've tapered people off, and it's just a joy to see they're living a normal life. And most of them continue their vitamin protocols, mostly to a big degree, but yeah, they can quite often live just a normal life, which is wonderful to see. So, and this is Dr. William Walsh's book, Heliobiochemistry, Heliobrain. It's available on Amazon. And of note is that Dr. Walsh just came out with a new book on bipolar disorder that I've been waiting for quite a few years for this to come out. It finally came out October 21st. I just got it. I haven't read it yet, but it's called The Essence of Bipolar Disorder. It's also available on Amazon now. And he I think was really looking into what is the root cause, because it's still such a challenging disorder to treat. And so I'm very excited to read that. So that's out there now. Yeah, and these are my resources. So, right. I know it was a lot of information. Yeah, so
That was wonderful, though. That was really, really insightful.
I'm so glad to share this because I wish more people would know about it, that that's out there and that that's an option. It requires some time. So if one ideally has a few weeks before an Iboga retreat to implement that and do it very gracefully that way.